So today we're going to talk about ventilations and proper oxygenation of your patients. One of the most basic things you can do is coaching a patient that is hyperventilating. When a patient's hyperventilating, what their body's starting to do is shunt blood away from the extremities, which causes a tingling feeling in their fingers, and they're breathing rapid, probably anywhere from 28 times a minute and up. And the normal rate of ventilations is 12 to 20 times a minute for your normal adult. Best thing you can do with that is breathe with your patient and talk to them to take deep, slow breaths in through their nose and out through their mouth. And sometimes you can also have patients create their own PEEP by using pursed lip breathing, which is causing them to keep more oxygen in their lungs at a time. That way their respirations will slow down. For saturation levels, you want to chase levels that are anywhere between 94% and higher for your patient. One of the most basic things you can do in this case is use a nasal cannula. Nasal cannulas are normally going to run from 1 to 6 liters a minute, and they're going to have a fraction of inspired oxygen at levels of 25 to 45. What you're going to do with these, you have 2 prongs at the end of your nasal cannula. After you have the oxygen running, you're going to place the prongs towards the patient's head, into the nares, wrap your cords around the ears, and you're going to tighten the tubing down at the base of the chin in order for the nasal cannula to stay in place. And this would be used more than likely in your patients with saturation levels of low to mid 90s, and you just want to get them a little bit higher. Another form that can be used for long-term oxygenation is humidified oxygen through a nasal cannula. What the humidified oxygen does, it gives you a higher concentration that is delivered to the patient over a longer period of time. That way the airway won't dry out. One of the next steps you can take for a patient who has a little bit lower saturation levels, which would be low to mid 80s, would be to take a non-rebreather mask, which is going to run at 15 liters, 10 to 15 liters, and get 80 to 100% of fraction of inspired oxygen. With this, after you hook it up to your oxygen tank, there is a flap on the inside of the mask that you're going to place your gloved fingers over. And you're going to let this reservoir bag at the bottom fill up with oxygen, because what this causes, it doesn't let the patient rebreathe CO2 that they've already exhaled. After your bag's filled up, you would take the mask and the bridge, place it over the patient's nose, and the strap will go around the back of the head in order to hold it in place. Bend the bridge to your patient's nose to have a better seal with your non-rebreather masks. And if you have the mask on the patient and it seems like it's a little bit loose, you can always take the strings on the side and you can pull them tighter, and it makes a tighter seal with the mask. The next step that's going to get a little bit more advanced because it's coming in with medications is going to be a nebulized treatment, which is going to be from 8 to 10 liters a minute, which is going to roughly be between 47 and 60% of fraction of inspired oxygen. Your nebulizer treatment is going to consist of using medications such as albuterol, which is delivered at 2.5 milligrams, a duoneb, which has albuterol, and ipratropium. The ipratropium is going to be at 0.5 milligrams to dry up secretions. If you hear wheezing in any of your lung fields of your patient. So this right here in my hand right now is a reservoir. You can either take and insert the medication through this hole in the top, or you can unscrew it and you can place the medication in the reservoir itself. After putting it back together, you would hook it up to oxygen. The blue piece of the oxygen tubing that comes with the nebulizer is going to go at the base of your nebulizer reservoir. After that, you have 2 styles that you can deliver this to your patient with. You can use the trumpet style, which is this piece right here, you have a mouthpiece on one side, and you have this side on the other that this tube connects to. Medication can escape through the tube, but if your patient's up to holding the nebulizer treatment, this is probably your best option because it also gives your patient some sense of control in the situation that's going on. If you have a patient that's a little bit weaker, they're complaining about being weak, they can't hold their arms up, don't really feel like holding their head up, one option you can do is use another face mask style. And it's going to work the exact same way that our non-rebreather did. The bridge goes over the nose, straps go around the head, bend to the nose to form a better seal, reservoir attaches to the bottom of the mask. And your nebulizer will last based off of how high you have your liters per minute set. The lower your liters, the longer it lasts. The higher the liters, the more the medication gets atomized, and it can escape around the mask, but at the same time, it's still going to do good for your patient. The other medication you can use in this case would be epi with a patient who's got stridor in the upper airways. You would take 1 milligram of epi and put it in 2 mLs of saline, nebulize it, and what that's going to do, it is going to dilate the upper airway. That way you don't have that high-pitched stridor noise anymore. A little bit more advanced airway, but it's still a basic skill, is going to be your CPAP machine. Normally a CPAP is going to come 2 parts. You're going to have your oxygen tubing with your PEEP valve, which is your positive end expiratory pressure. And what that's going to do is going to help the patient's lungs stay expanded after they expirate their breath. So connect this to your CPAP mask, and it's got all these straps on the back of it. What you're going to do with that is you're going to take the seal, which is at the back. It's going to go above the bridge of the nose, around the bottom of the mouth, the straps that go around the head, get them placed on. And they have snapping points on the front of the mask. After having that connected, you have many different settings for PEEP you can give with this patient. If you run it at about 5 liters, you're going to get about 8 to 9 centimeters of H2O. You run it at about 7 to 8, you're going to get 10 to 12 liters, 10 to 12 centimeters of H2O. 10 liters will be 13 to 14, and 13 liters will max your PEEP out at 15. With patients like this, you're looking to hear rails in the lower lung fields, and in a lot of times this is going to happen in your CHF and COPD exacerbation patients. A lot of times nitro is going to be used to assist to relieve some of that pressure that the patient's feeling in their chest. Before you place a CPAP, you can use 0.4 milligrams sublingual up underneath the tongue of the patient, or you can do 2 inches of nitro paste on the chest after application of your CPAP. If you have a patient that starts to get to where they cannot tolerate the CPAP, it's probably a good idea to take the CPAP off the patient, because you don't want to make the patient more irritable and make the situation worse. And if you hear wheezing, all you got to do is take your nebulizer treatment that we just talked about, hook it up to the bottom of the PEEP valve, and you're giving the patient positive end expiratory pressure along with helping dilate that airway so you don't have any more wheezing either. So that's what we got for our conscious patients. But you might wonder, what are you going to do if you walk up to a scene and you have a patient that's unconscious? So there's 3 main maneuvers that you can use with nothing to help open a patient's airway. That's going to be your head tilt chin lift for the first one. All it does is you bring the patient's head back some, and you're going to take 3 fingers, place up under the jaw, and you're going to pull up. And what this does, it helps displace the tongue over the glottic opening. Another maneuver you can use is a jaw thrust, where you won't move the patient's head. This would be used more in your trauma situations when you're worried about a C-spine. So what you would do, you put your thumbs on both sides of the patient's cheeks, Place your fingers up under the mandible of the jaw, and you're going to push up. And it does the same thing the head tilt chin lift does by displacing the tongue. You got a patient that's unconscious, say somebody told you it was a witnessed fall. You've already tried both of those techniques, they didn't work. You can try putting the two techniques together in a skill called a triple airway. You're going to use the same hand formation that you use for the jaw thrust, but instead of just thrusting the jaw up, you're going to use the palms of your hands to rotate the patient's head back, and then you're going to push up the jaw. Say that doesn't work and you still can't get good airway on them. You have small little pieces that you can try to get extra air to them with. You have MPAs and OPAs. We'll talk about the MPAs first. MPA, you're going to measure it based off of the size of the nair of the patient, and also you can measure it from the corner of the nose to the tip of the earlobe. It's got a bevel side on it. Most of the time you're going to want to put this through the right nair due to the right nair being larger than the left. And the way the MPA is formed, it flows easier. Most of the time you're going to want to use lube. If you can't get your hands on any lube, you know, most patients do have some saliva secretions in their mouth. Just go like that. Don't push it down the airway to where you're going to make them choke on it though. Just, you know, spin it around a little bit, get something on it. Put the bevel side facing towards the middle of the nose. It's just going to insert good and sweet like that. For your OPAs, you're going to measure from the corner of the mouth down to the base of the mandible. For these, you're going to want to make sure your patient doesn't have a gag reflex before you try to use it. One way you can do this is tapping on your patient's eyelid and seeing if they have a twitch. If they don't have a twitch, there's a high chance that they don't have a gag reflex. So when you go to insert it, you're going to put it in. Be careful of soft palates. You don't want to damage those, because if you cause bleeding in the airway, everything you're doing is for nothing. Enter it like this, then you're going to rotate and you're going to finish positioning the OPA, and all it does pushes the tongue over the glottic opening, giving you a more secure airway. Say your patient did have a soft palate, you got the OPA in, you start seeing some blood, more secretions coming up in the mouth. One thing you can do is you can suction the patient to make sure nothing falls into the airway, and you don't want blood to fall into the stomach either. But just be careful not to suction for more than 10 to 15 seconds, because you don't want to lower their saturation any more than what it already is to cause more harm. And what we'd use for those, we'd use wide bore suctioning such as decantos, or we could use soft suction such as our French tip or whistle tips. Next thing, say you come up on a scene, patient's not breathing at all. One skill you can use is a one-way valve. Your one-way valve is going to be a simple face mask that is used for you to be able to manually give a breath to a patient, which is going to be you taking the mask, placing a seal over the patient's bridge of the nose and bottom of the mouth, and you're going to give a breath out of yourself, which is going to give them about 21% oxygen. Be careful with this though, because you need to take BSI risks. This is going to be any fluids that could come out of the patient's mouth, or, you know, the patient could be sick. You know, just try to keep as good of a barrier as possible you can between you and the patient while doing this. The next part we're going to talk about is a BVM, which is going to be, most of the time you're going to have it hooked up to 15 liters a minute, which is going to give you 100% of FiO2. The proper rate of respiration of an adult patient is going to be anywhere from 12 to 20 times a minute. So if you're going to breathe for the patient, breathe at about every 5 to 6 seconds. That gives you about 10 to 12 breaths a minute. It's going to give them proper oxygenation. When you're doing this and you're a single rescuer, you're going to use the EC clamp. And when you're breathing for the patient, you're going to look for equal chest rise and fall on both sides. Also check for lung sounds to make sure you got lung sounds on both sides. If you don't hear lung sounds on one side, this patient probably already has barotrauma. And you need to be careful when you're squeezing the bag, because if you squeeze this whole bag multiple times in the patient, there's a pretty good chance that you've caused more barotrauma than what was already there, if it was already there. If you're using a 2 rescuer technique and you want to get a firmer seal, you can take 2 rescuers, and I'm going to remove the mask to show you this, but you can use a double EC clamp technique, and it makes a firmer seal. That way when the second rescuer squeezes the bag, you don't have as much oxygen escaping from around the seal. Normal tidal volume is going to stay at about 500 mLs per inspiration. The bag's got 600, so squeeze about half of it every time you breathe for the patient. Hope y'all enjoyed this, and that's it for this lesson.